Well, good morning. As the program director, I have the honor of introducing our third-year resident, Dr. Meis, today's Grand Rounds speaker. Dr. Meis comes to us from Lamars, Iowa. In 2012, Megan achieved her Bachelor of Science degree in Nutritional Science, graduating magna cum laude at Iowa State University. Her undergraduate days were not just in Iowa. She studied Spanish for a semester at the University of Arkansas and spent another semester, this one abroad, at the University of College Cork in Cork, Ireland. In the summer of 2012, Megan matriculated at the Des Moines University College of Osteopathic Medicine as a Rural Medicine Education Pathway Scholar. During her years at medical school, Megan worked as a clinical medicine teaching assistant and as a lecture note taker. She also volunteered at local nursing homes. Megan obtained her medical degree in May 2016 and shortly thereafter joined our residency program. In the time that Dr. Meis has been with us, she has established herself as an academician and an advocate for adolescents. She is currently co-writing a manuscript on celiac disease to be submitted to the peer review journal, South Dakota Medicine, and she has advocated for HPV immunization in the community. Dr. Meis is also a clinical instructor in our Department of Pediatrics at the University of South Dakota Sanford School of Medicine. When Megan graduates from our program in June next year, and she will graduate, she will be setting up practice in Orange City, a town with a population of less than 20,000. In fact, the 2010 survey was 6,008, I believe. And she's doing this in return for her rural medicine scholarship. Now, when I write these introductions, I always like to go back to the personal statement to see if there's some quote in there that can apply to the title. So, in her residency application, Megan wrote, "In kindergarten, my favorite foods were butter and sugar, and my favorite colors were pink and purple. Although I may have been on to something, this simple reflection reminds me that the preferences we have and the choices we make can change over time, often for the better. By taking a moment to step back and analyze my career goals, I believe I finally have an answer to that infamous question, so what do you want to be? I want to be a pediatrician." All of us at Sanford Children's are certainly glad Dr. Meis, a very good-hearted resident, whom some of us call Bad Megan, chose to become a pediatrician. So please welcome Dr. Meis, who will talk about obvious yet overlooked understanding pediatric obesity. Welcome.
Thank you, Dr. Zenel. I would say the one correction or change I have is that my last name is actually pronounced Meis, but otherwise very good. So I'll go ahead and get started here. In deciding what to talk about for Grand Rounds, as Dr. Zenel mentioned, my major was nutritional science in undergrad, and so I've always been drawn to nutrition and preventative medicine. That's one of the reasons that I picked pediatrics. Initially, when I was trying to decide what to call this talk, I was debating calling it like addressing the elephant in the room. I didn't want to call it that because I thought some people may think it's offensive or that I'm calling children elephants, but I do feel like pediatric obesity is one of those things that a lot of us see and recognize and are aware of, but are really uncomfortable bringing up in the sense of it being the elephant in the room. And so my goal is that by giving this talk, hopefully it will help make people more comfortable or at least know what to say or how to bring up this topic. So just kind of going through the different objectives that I have here today. We'll go over the prevalence, the definition, diagnosis of pediatric obesity, talk about some of the consequences if it's managed poorly, and then discuss some different motivational interview techniques that are out there that can help promote healthy lifestyle changes, as well as emphasizing why it's important to diagnose and prevent pediatric obesity. So looking at the definition of obesity, it's pretty simple. It comes down to having excessive body fat. One of the main ways that we measure that is by looking at the BMI, and that's a calculation of the weight in kilograms divided by the height in meters squared. It's important to note that the BMI is, a screening tool. It's not a perfect test. It's not gonna give you the best estimate on everyone. I know the argument for a lot of people is those more athletically built kids that have higher muscle mass sometimes come up as having a higher BMI, but are they really less healthy? I think the important thing to just consider is that BMI, we use it as a screening tool, and you have to kind of take that into account. For kids, kind of the different cutoffs for healthy weight would be ideal range in between the 5th and the 85th percentile. Anything below the 5th percentile would be considered underweight. Anything in that 85 to 95th percentile range would be overweight, and then anything above the 90th percentile would be obese. So here's a lovely growth chart here, and again, it's important to make the distinction between pediatrics and adult medicine. Adult medicine, they'll use just the general BMI number, where under 18 would be underweight and over 30 would be overweight. But for kids, we really want to use that percentile just to take into account for their growth. And so, this is something that we're doing at every visit. We're looking at their weight and height and plotting it on the growth chart and seeing where they fall, looking at trends. If they're under 2 years old, then the BMI doesn't necessarily apply. It'd be the WHO growth charts, and it'd be more looking at the weight for length. If they're above 2, then we use our CDC growth charts for BMI. So prevalence, and I had a hard time finding newer data out there. A lot of the data is from the last 5 years. I know pediatric obesity had been a really popular big topic within the last 5 to 10 years. But I think a lot of the numbers still hold true, that they're estimating about a third of children in the U.S. are classified as either overweight or obese, and that number has tripled since the 1970s, and that's why it's such an important topic to talk about. Some of the data said that about 1 in 5 kids ages 6 to 19 are considered obese, and you can see one of the lovely map graphic representations just with the shading of which states have higher prevalence rates than others. South Dakota falls within that 30 to 35%. With the red, you can see we're not quite as high as our neighbors to the north, but still, doing a little bit worse than the rest of the Midwest. So definitely something to talk about. So obesity prevalence also varies a lot between different ethnicities and groups. Most common in the American Indian, African American, and then Hispanic populations than non-Hispanic whites. And one of the main risk factors would be just the fact that if one parent is obese, then it's going to increase the risk 2 to 3-fold. If both parents are obese, then that increases the risk by 15-fold. So it's really important to look at the parents as well, because that can also indicate what kind of risk level you're working with. It's also much more prevalent in the less educated rural populations or those with lower income. So this is just a graph kind of showing that we see the increasing trends as kids are getting older. Thankfully, most of them are in that overweight category and not the obese or severely obese, but we do see that the numbers change over time, that the adolescent is the highest of all of those, and we'd expect those trends to continue into adulthood. Another thing with prevalence, it's more common in the resource-rich countries, which makes sense. Highest in North America, South America, Great Britain, Greece, Italy, Malta, Portugal, Spain. Less common in some of the lower resource areas. Etiology. So it's pretty simple when it comes down to, why obesity happens. It's really a misbalance of energy. The energy out is not quite as much as the energy in, and you know, if you think it's such a simple solution, then why haven't we fixed it? There's a lot of complicating factors that play into that simple balancing scale, and you know, I've listed just a few on the slide here, but you know, I think there's several others that are playing in as well that I don't have on the slide, but some of them, you know, genetics, metabolism, sleep, community factors, and then your physical activity, nutrition are all playing a role. So to go through some of the environmental factors, you know, increasing trends in glycemic index of foods is something to consider. Sugar-containing beverages, you know, I know the AAP recently made the recommendation against fruit juice, and that was a change from previous years. Portion sizes is clearly a problem in this country. Poor sleep habits can contribute, and then, you know, even just fast foods or convenience foods, prepackaged foods, prepared and processed foods, we kind of see. I know, you know, I've heard the acronym for Standard American Diet as SAD, and I do feel that that can be true sometimes. Also, there's, you know, less of a family presence at mealtime. You know, it's kind of more, we're a busy on-the-go culture, and people don't always, you know, have that set time where everybody sits down at the dinner table and has a meal together. It's becoming, you know, less frequent. Also just less structured physical activity that's happening with an increase too in the electronics, screen time, computer activity, TV, Netflix and YouTube and all these things that we're spending more of our time doing. I know public health efforts had been kind of triggered more towards school meals and school nutrition, and focusing on that as well. Sugar sweetened beverages, you know, I talked a little bit about this already. It's something that they've really shown to have a connection with obesity. You know, the average caloric intake for a sugar sweetened beverage is around 270 calories, which, you know, when you look at it, ends up being 10 to 15% of total caloric intake recommended a day, and you know, that can add up pretty quickly throughout the day, especially if they're having multiple. And so, you know, they've shown that reducing consumption of some of these sugar sweet beverages has had an impact on BMI. And so, you know, that raises the question of, I know they've brought up like taxation and things like that, public policy, like should we put tax on soda or juice or anything like that? And you know, I'm not here to talk about that today, but that's certainly something to consider. For electronic media, TV has kind of a bad reputation for obesity as well, for several kind of reasons. You know, obviously, if you're watching TV, then you're not going to be very active. You're usually sitting on the couch or a chair or something. You're not really moving very much, have depressed metabolic rate. And another thing too, though, we don't always think about is the effect on the diet. You know, whether that's, you know, making a bag of popcorn to watch your movie, or snacking on some Cheetos, or just watching TV and there's commercials on there for Dairy Queen or McDonald's or something like that. And well, I'm not saying that that makes you stop and go drive to Dairy Queen. Like, you might just be like, oh, I am kind of hungry, and grab something out of the fridge. And so, you know, that can have an impact as well. Also, we know that screens can influence sleep, and sleep is just really important for weight management as well. And so, you know, if they're watching TV late into night and then can't fall asleep for a while afterwards, that's a concern. Video games are also associated with obesity, but I guess numbers have shown a little bit weaker association than TV, and that would mainly be you know, the theory would be, well, they don't have those commercials in there, so maybe there's less of that impact of, oh, I need to go to McDonald's. And I'm not picking on McDonald's, but so medications too can play a role. You know, in pediatrics, this is less common than maybe adult medicine, but certainly something to consider. A lot of the psychoactive drugs that I have listed there have been shown to be associated with some weight gain, and so specifically our kids that have, you know, depression, anxiety, or seizure disorders would be at risk. as well as our glucocorticoids. This is something that I feel like is used across specialties, whether it's for asthma management or like Crohn's disease, allergies. Like we use steroids for a lot of different things, and that's maybe one of the ones that we see more often in kids. And so considering the fact that, if Johnny has really poorly controlled asthma and he had like 3 steroid bursts within the last couple months and is gaining weight, like could the steroids be playing a role? I think it's very possible. And then of course, underlying etiologies or other things that could be going on. I think that this is more the exception than the rule. It's important to always consider, could there be some other reason for why a child could be obese? I've listed some different genetic syndromes on here. I think all of us are probably most familiar with like the Beckwith-Wiedemann or the Prader-Willi. Endocrine disorders, I know our endocrinologists probably get a lot of referrals for pediatric obesity, and as far as the percentage of is there truly an endocrine cause behind it, I think it's not as high as other providers maybe would think. Certainly cortisol excess, or like I mentioned with increased steroid use, could play a role. Cushing's disease, hypothyroidism, growth hormone deficiency, or even pseudohypoparathyroidism have been associated. But there's also hypothalamic obesity, which can be caused by a lot of different things. I know, whether that's tumor or trauma or inflammatory disorder. They talk about like after craniopharyngioma surgery. This gets into some of the more rare things. I talked about this ROHOD and this ROHOD net, which honestly I wasn't very familiar with before kind of doing this research. And so I think that these things are much less common, but still something to consider. Metabolic programming is something that's a little bit newer, at least from what I'm gathering, something that's a newer theory. Epigenetics is kind of a newer area of medicine that we're still trying to understand. But it's focused more in on the fact that what happens during pregnancy can really play a role in the future outcomes of the child. So they've shown that maternal body weight and nutritional factors during the pregnancy can have a role. Kids that were born SGA or LGA or premature can sometimes have increased insulin resistance in the future. And, obviously that's associated with a number of different conditions as an adult that they can develop. They've also shown that, moms drinking more sugar-sweetened beverages during pregnancy maybe have some increased adiposity risk later on. Breastfeeding is beneficial and awesome for several different reasons. And so it's, of course, we always promote breastfeeding. But I think it gets tricky for nutritional goals for these premature children who, we know that we want to have catch-up growth for them so that they can have the best neurodevelopmental outcomes. But, where do we draw the line where if we're doing too much with the catch-up growth, could we be, contributing to future metabolic disease risks later on? So special healthcare needs, another thing to consider, our population of children with more chronic medical conditions, whether that's like cerebral palsy or trisomy 21, things like this, where they have other factors involved. I think it's just a smaller risk, but still increased risk. The numbers I saw was like 20% instead of like a 15%. And so, that could be related to the fact that, these patients might have difficulty chewing or swallowing foods. They're a lot of the time on the medications that I had talked about on the other slide that can contribute to weight gain. And then also, they're limited in their physical activity. A lot of them are, bound to a wheelchair and only really get movement when they're working with their physical therapists or occupational therapists, and don't get as much movement as some other kids. Community factors also play a role. Obviously, it's tough to make healthy choices when you're surrounded by an unhealthy environment. And so, I've heard people talk about, like, yeah, it'd be hard to be on a diet when you work in a donut shop or at an ice cream shop or something like that. And I think that's very, very true. It's a lot easier when you're in a supportive environment to make lifestyle changes. Daycares and schools and communities can have a really big impact on health, just depending on, what's available or offered for them. Another factor too that, I didn't necessarily consider is just the safety of the neighborhoods. If kids are growing up in an unsafe neighborhood and parents really don't feel comfortable with letting them go to the park down the street, they might feel more safe if they're, in the next room watching TV than sending them out into an unsafe neighborhood where, they're not going to get as much opportunity for physical activity. So this is my lovely slide with some of the things that can happen as a result of obesity. Obviously a lot of these are more adult problems, but kids become adults, which is why we're talking about this in the first place. But you can see there, a number of different things that are tied to obesity and consequences as an after result. So kind of going through the different consequences here that we see, specifically high blood pressure, high cholesterol can be seen, and obviously those contribute to like cardiovascular disease. They can have impaired glucose, which is all tied in with insulin resistance and potential type 2 diabetes development. Breathing can be a concern, whether that's with asthma or sleep apnea. They can have musculoskeletal complaints or joint pain. Sometimes some GI things, whether that's like fatty liver, gallstones, reflux, and certainly lots of psychological outcomes, anxiety, depression, low self-esteem, low quality of life. A lot of social problems that go on at school. These kids are picked on, and I think it has a lot of lasting effects that we don't always consider. Certainly the future health risks we already touched on. If a child is obese, they're a lot more likely to be obese as an adult, and with that too, if a child is obese, then they're more likely to have a higher degree of obesity as an adult. And I've listed there too the things that can go along with obesity. So diagnosis and management, we already talked a little bit about the BMI and looking at the percentiles. That's really like kind of your main way to identify a child who's at risk. So always plotting those things out, looking at the growth chart. If the child falls within normal range, I think that's an opportunity to praise the child and the family and say, hey, like you fit within the range that we expect. If they're still within the range, but you've noticed that they've kind of jumped percentiles, so, say today they're at the 70th percentile, but last time they had been at the 50th percentile, I think that's just an opportunity to point out like, oh, like I noticed that the percentile went up, maybe just talk about that a little longer. You certainly don't need to focus in and spend a ton of time, but I think just making them aware is helpful to families, because a lot of the time, you see your child every day and you don't realize these changes that are happening. For kids that fall within the overweight category, it's a little bit more education and materials to provide, talking about follow-up plans, maybe like every month, to reinforce healthy habits. For the obese kids, kind of same lines, but then you may consider doing screening tests depending, consider getting like a glucose or A1C, maybe getting a lipid panel or liver function test just to see where they're at. And then, later down the line, you may consider a more organized weight loss program. So this is kind of the 4 stages of treatment that I've seen out there. It's kind of like a tiered approach. The first one, Prevention Plus, is really just driven by the primary care provider, where you're just talking about healthy nutrition and physical activity, behavior type things, and just follow up every 3 to 6 months or so. For stage 2, it's a little bit more structured. You might involve like a dietitian or a counselor as well, and talk about some more specific goals, increase parental supervision and involvement, maybe have them tracking what they're eating. They have a lot of like apps out there and stuff, and So there's a lot of different tools that are available. For stage 3, comprehensive multidisciplinary intervention, that's really the whole team that you have, kind of have everybody on board, and again, like all very similar steps, but just a little bit more structure and a little bit more focus towards the net negative energy balance. For stage 4, the tertiary care intervention, this is something where it'd probably be a referral to a different facility. They do have obesity medicine physician specialists out there. I don't know if there are any in this area, but certainly that's for the very highly structured diets or medication management, and may even talk about like bariatric surgery as a treatment option. So motivational interviewing is something that, has really been shown to be the most effective for talking to patients about obesity and management. It's something that's patient-centered and was actually initially developed for treatment of like addiction medicine type things. I've included the graphic on here with the different stages of change or readiness for change, because obviously we know that if you have a family who is not at all willing to make a change, if they're in that pre-contemplation stage, then it becomes very difficult to, make strides towards change if they're not there yet. And so I think it's important too, just to recognize where your families are at. They can obviously move from step to step throughout the readiness for change. But when you are ready to use motivational interviewing, it's something that incorporates reflective listening while you're encouraging patients to make a behavioral change. And so it's important that this is a very non-judgmental, empathetic, encouraging environment. There can be some terms, like even just the word obese itself, people can find derogatory or offensive. Certainly fat, I think, is something that we used to be used a lot more often, but we've kind of gotten away from that. But the reason that we don't want to use language like that is just to prevent defensiveness. Because once people get defensive, I feel like they kind of shut off and don't really listen to anything you're saying anyway. So it's really important for there to be like a family focus on achievable goals. It's important not to be like, okay, Johnny needs to lose 10 pounds in 2 months. Like, that is not at all the goal. It's more of a, how are we going to achieve a healthier lifestyle, not like a number for weight loss. So some different tips with the motivational interviewing. Important to always ask open-ended questions. Make sure you're listening reflectively, asking for permission, making sure that you're honoring the patient's autonomy. I think the major challenge in, a clinic setting for motivational interviewing is that it does take some time to really go through this process. And if you're at a well visit and you have like 15 minutes or more realistically, maybe like 5 minutes to talk about this stuff, you're really not getting a good opportunity to kind of delve into the depth that you need to in order to address it properly. So, ideally you'd have a little bit longer visit to be able to talk about these things. But you want to avoid coerciveness or talking them into things. You kind of want it to be their idea and primarily come up by them, because if they came up with the idea, then they're a whole lot more likely to follow through with it. And so there's different techniques that I'll go over on the next slide too, just with more information. But it's important to ask about how confident they are that they'd be able to make this change, and then for them to kind of summarize everything that you talked about, and then obviously focusing more on their successes than failures, because we know that there are lots of ups and downs and they can't be perfect 100% of the time, but focusing more on the successes is always a positive thing. So this is, I don't know how well you can read this, but this is an example that I found on the American Academy of Pediatrics website that I thought was pretty helpful to kind of demonstrate what motivational interviewing is like. I personally like examples better, so I'll kind of read through here just because I'm not sure how well you guys can read it. But for the elicit provide elicit tool, like an example would be the doctor can say like, oh, would it be okay if we discuss Ralph's TV habits? And then, mom's like, okay. And the doctor kind of goes into more an informational approach where we see a lot of kids these days who are watching more than 3 hours of TV a day. We know it can affect their health. Watching TV can lead to weight gain because they're not as active and because they may be eating more snacks while they watch TV. Kind of gets to the point where American Academy of Pediatrics recommends that kids watch less than 2 hours of TV a day, and then, they go on to say, how do you feel about that? And so then it's kind of, not saying like, oh, your child is doing something wrong. It's more of a, this is our general recommendations. What are your thoughts on that? And, that opens the door for mom to say, I see what you're saying. I know that Ralph's not getting as much exercise as he should, but I'm just not sure what to do about it. And so then you can go on to more of a importance and confidence scale type interviewing where they do a lot of the scale rating stuff. I think we use the 0 to 10 for pain most frequently, but it can be used in a lot of different things. And so, the doctor says on a scale of 0 to 10, with 10 being the highest, how important is it for you to control his screen time? And, mom might say, oh, it's maybe an 8. So, pretty important. And then that gives the doctor the opportunity to say, well, on a scale of 1 to 10, how confident are you that you will be able to control the screen time? And then, parents might laugh and be like, well, more like a 4. So then that gives you the opportunity to, identify barriers that are in the way with, obviously there's a discrepancy between you're saying importance-wise, this is an 8 for you, but realistically, it's more like a 4 for what you're going to be able to do for change, and why is there that difference, and what's in the way, and what can we maybe do to bridge the gap. So this is just a list of challenges and solutions that I found to kind of go through with parents. A lot of this is pretty basic stuff, but just kind of good to walk through and see what are the barriers that patients are facing, and what are some things that we can suggest to them that might be helpful. So one common barrier would be that families don't have a lot of structure to their dietary patterns. They just kind of, eat whenever, grab a snack here and there, and don't have set meal times or anything like that. So in that sense, I think it'd be important to try to encourage families to eat meals together and have them a little bit more scheduled, not to skip meals if possible, just because, oftentimes if a meal is skipped, then you might be really hungry later on and overeat or eat more snacks than is recommended. And so another thing would be, to avoid any distractions during the meal time, and that would include things like television. Another challenge is, maybe the child is super motivated to be active out there, but really doesn't want to change anything with their diet. And I think it'd be important there to emphasize that, we talk about the scale of energy balance, and there's kind of the two sides to it. And if you're only going to be working on one side, it's going to be a whole lot harder to move that scale. Physical activity is important, but so is nutrition. And, some people argue which one's more important. Obviously they're both very important in maintenance of weight and energy in versus energy out. And then, family frequently eats meals away from the home. And I think that this is something that comes up, very commonly today. And sometimes, it's difficult to overcome. People are very busy and there's a lot going on, and it's difficult to have like scheduled, structured meals at home. But just kind of talking to families about like why this is happening, or why, is it realistic for them to try to do more meals at home, maybe helping them with meal planning resources, or helping find recipes that are more familiar to some of the foods that they like and eat a lot of, maybe helping just find some easy recipes that they can use. And then, if it's really not an option for them to eat at home, just talking about what restaurants they're going to. And, whether it's switching to a different restaurant or just making different choices at those restaurants, that could be helpful. Larger portion sizes, this is something that's been talked about a lot. I think just over the years, portion sizes have increased from what they used to be, and so, making sure that there's mindful eating and that you're providing the tools and education for, like, am I hungry, cues for hunger, things like that. Fast eating pace, I'm definitely guilty of this, like when I'm busy sometimes on rotations, but it's important to recognize fullness and really be mindful of what you're eating, making sure you're slowing down. Just really being more aware of things. Poor dietary quality. This is another thing that we see pretty frequently. It's important to talk about some of the different food groups and what we recommend. This choosemyplate.gov is a really great resource that's out there for families or even, providers. They have lots of different posters and things that you can hang up in your office that show, like, the visual, a quarter of your plate is vegetables, a quarter grains, a quarter fruits, a quarter of protein, and sometimes that visual can help families too, just to kind of be more cognizant of what types of foods they're picking out and what to kind of have on their plate. Lacking nutritional knowledge. This is something that I think is a lot more common out there too. We don't get, especially medical schools, I know, don't have a lot of nutritional education. They're kind of moving more towards that now. But sometimes you take for granted that it's like, oh yeah, like, obviously that's not a healthy food choice, but not everyone knows that or realizes that. And with marketing and things like that, like, I mean, again, not to pick on Lucky Charms, but like Lucky Charms, like whole grains on the box. And I think a lot of the times families will, see those kind of health buzzwords and think that this is a good choice when it may not be the best choice. And so just kind of educating them to, like, what's really healthy and what's not healthy. And just because it says organic or fresh or something on the label doesn't always make it a good choice. Just for them to be more aware of good choices. And then, you can kind of gradually work up on the education. I wouldn't give them like a whole big lecture on proteins and things like that when they're not ready for it. Just talking about how do you look at a label and, what are things to look at and avoid. So excessive refined grains like white breads or simple carbs like sugars, the nutrition field really changes a lot over the years, and I think that's, a main struggle with people. I know earlier on they had the whole low fat, no fat craze where, people are only fat because they eat fat, and it just gets really confusing to know what to follow because there's such a change in recommendations. Now it seems to be more of the, like, carbs are evil and avoid, no carb diets or avoid sugars and things like that. I think the importance is just to emphasize, including fiber in the diet is helpful for a number of different reasons, whether it's managing constipation in our kids or just having them feel more full after they eat. If they eat like a piece of white toast for breakfast versus like a bowl of oatmeal, they're probably going to be full longer if they have more whole grains in the diet. Then high fat dairy intake, again, like, this is something that recommendations have changed a little bit over the years. I know, whole milk used to be something that we really pushed in our younger kids, and now it's kind of gone more towards like skim milk and 1% milk that we recommend. So just, again, talking about the differences in fats and healthy fats and avoiding the trans fats and saturated fats. Like, that's a pretty agreed upon area that those are things that we want to avoid. Skipping meals, we already talked about this a little bit, but having more scheduled meals or scheduled snacks throughout the day can help prevent from overeating or over snacking or making those, unhealthy decisions. I think everyone's been there where, if you're hungry, then no matter what shows up, like you're going to eat it. Like your body wants food or fuel, and your choices for nutrition go to the backside if you're hungry. And so sometimes it's nice just to stay on top of the hunger management to make the best decisions for what you're eating. And then, some people are just not big meal eaters of a certain, like there are lots of people out there who don't like breakfast. And so that becomes a challenge too, because I think the problem is with nutrition is that it's not a one size fits all thing. It's a very individualized, and, maybe not eating breakfast for some people can work better than for other people. But especially with kids who are growing, I think even just having families trying to give them a little something to start off the day, whether that's just like a banana or something, just so that they're not, being hungry and over snacking or making poor choices later on. Kind of excessive snacking along those same lines, trying not to do more than like two snacks a day, having healthy snack choices available, not just going to the vending machine or something like that, but sometimes it's good if they have like a pantry shelf that has healthy snacks, or a place in the fridge that's like, oh, this is where you can go to for your snack, and this is, the choices that you have. And then the sugar sweetened beverages again. So yeah, avoiding those if possible. The AAP I know talks about no more than like 4 ounces of juice a day. So in those families that are really like stuck on the juice and love their juice, like even just talking about changes that are more likely for them to make. So, instead of completely eliminating the juice, if they maybe dilute it down to half water and half juice, or try to cut out at least one of the glasses of juice, then all those little things can add up over time. Low fruit and vegetable intake. Fruits and vegetables are not classically kids' favorite foods, and so just talking to them about importance of fiber that they get from these things, maybe having the family try new things, or really getting the kids involved in grocery shopping or gardening or whatever else, just to have them have a piqued interest, going through different recipe ideas that make it more fun. Picky eating, again, this is a pretty common topic in pediatrics, and helpful to introduce new foods gradually. Just because they didn't like something one time doesn't mean you should never try it again. I think it's important to be repetitive in the introduction of things, and that's where a lot of parents maybe give up, where it's like, oh, well, we tried broccoli once and they didn't like it, so we don't do that. But it's important to just re-offer, not cater to the child. Like if the family is eating a taco salad, then don't give Johnny his own personal pan pizza or something just because he doesn't want to eat what everybody else is eating. And then, you don't want to force feed a child a food that they don't like, but just, again, have it offered there, like this is what we're eating tonight, this is the food that's here, and then just kind of letting them know that that's what their option is. So the 5-4-3-2-1-0 rule is something that I know Dr. Nelson had kind of showed me in clinic, that I think is easy because you've got 5 fingers, and it's easy to kind of focus in on what are overall nutrition goals. That's something that you can quick talk about in a visit that kind of covers the basis of everything you want to talk about. So, when you're talking to families and visits, you can say every day the goal would be to have like 5 servings of fruits and vegetables, 4 servings of whole grains, 3 servings of low or non-fat dairy, and then, 2 hours or less of screen time a day, 1 hour or more of moderate activity, and then 0 or almost 0 for sugar sweetened beverages. Okay, so this is where I'm going to try to play a video here. This is kind of what inspired me to pick this talk. I've talked about my interest in nutritional science, but I was watching the news last fall and I saw this little clip on a pediatrician in Virginia that I thought was really interesting and cool, like what she's done with her practice. So let me see if I can figure out how to bring it up here. Maybe. Come on. The internet connection is so slow. We did get it to work when we tried it beforehand, so. Guess we'll have to watch a 15-second ad
Fight
first.
security threats 60 times faster with AI that sees threats coming. The IBM Cloud, the cloud for smarter business.
You gotta smile.
At Dr. Namali Fernando's office in Spotsylvania, Virginia, patients still say ah, but they also say Every day, the pediatrician trades her white coat for an apron and enters her fully functional teaching kitchen.
Where did this idea come from?
A frustration of seeing so many children with pediatric obesity.
Instead of lecturing patients on the benefits of good nutrition, she now shows them smoothies, salads, how to get even the pickiest eater to celebrate spinach.
I love it. I had to really show them how fun food can be and show them how to prepare the food. Another meal maker.
Fernando also started the Dr. Yum Project, bringing nutrition to schools and camps. Kids tend to the garden, then turn the fruits of their labor into delicious dishes. It's working. 15-year-old Michelle Castro was pre-diabetic.
Get more fruits and vegetables in your diet.
Now she's lost more than 10 pounds and has fewer health problems.
It's a great day for me if I give more recipes out than prescriptions.
Cooking up a new take on medicine.
They're very crunchy.
Just what the doctor ordered. Kristen News, Spotsylvania, Virginia.
Okay, so yeah, I guess to try to end on a positive note here, we are, making some progress with pediatric obesity, especially the younger kids. I know that they have some more recent data out there that's shown, rates have gone down from like 14% to 10% in the kids under 5, and I think that that's really exciting. There have been a lot of public health initiatives out there and programs. I've listed just a few on the slide that focus towards prevention of pediatric obesity. I think, all of us can say that there's a whole lot more awareness than there had been 5 or 10 years ago, but there's still a lot of room for improvement out there, and that's why I wanted to talk about this today, just to kind of give you guys tools and resources and hopefully a little bit more comfort level in talking about pediatric obesity. This is kind of the end here. I've got my references slide, but then go ahead and open it up for any questions. I don't know if outside people have questions or inside people have questions.
Yes, thank you, Megan.